Very good evening, one and all. I am Vaishali Nath, Medical Advisor at Ajanta Pharma. And on behalf of Ajanta Pharma, it's our privilege to welcome all our experts on board today for our Cardio Master Workshop Edition 5, a signature academic initiative designed exclusively for our young cardiologists in training. So today's session, we will promise to stimulate and enrich a lot of learning experiences as we deep dive in one of the most crucial and challenging area of cardiology. Our Cardio Master workshop has been very carefully guided and curated under our eminent course director, Professor Dr. Ajay Mahajan sir, who is associated with, who is a HOD of Department of Cardiology, KEM. Welcome, sir. Along with sir, we also have with us Dr. Dheeraj Kumar sir, who is intervention cardiologist and assistant professor department associated with KEM Mumbai. Welcome sir on board and thank you for giving us such an wonderful program. And joining them are senior faculty today, renowned intervention cardiologists and pioneers in pediatric and adult congenital cardiology who have dedicated their most of life in advancing cardiac care and inspiring the next generation of specialists. We have with us Professor Dr. Jaya Ranganathan sir, who is HOD Department of Pediatric Cardiology, Bangalore. Welcome sir on board for our today's event. We have with us Professor Dr. Anita Saxena ma'am, who is Executive Director associated with Fortis Escort Heart Institute, New Delhi. And to add to this, ma'am is also recognized among the world's top 2 scientists in the year 2025 by Stanford University. Many congratulations to ma'am. We also have with us on board Professor Dr. S. Ramakrishna sir, associated with Department of Cardiology, AIMS, New Delhi. Sir is also one of the top 2 scientists recognized by Stanford University in the year 2025. Joining them, we have with us Professor Dr. Charan Lanjewar sir, associated with Department of Cardiology, KEM, Mumbai. Welcome to our all the expert on board today. Today's topic is on a very interesting topic, as I have mentioned. It is going to be on the congenital heart disease, and our expert speaker for today's evening, who is going to take us through the approach of cyanotic heart disease, is none other than Professor Dr. Anita Saxena ma'am. Thank you, ma'am, for once you will be sharing a very insightful topic regarding the same. We also have with us expert panel on board. And today's case will be presented by the DMPG student Yash Sharma sir and Subhash Chetri sir. Welcome on board, sir, as well. So with this brief introduction, without taking much of time, I would like to hand over the session to Charan sir to set the context further.
Good
Over
evening.
to
Thank
sir.
you very much, all the experts. And I welcome Anita Saxena Madam, Dr. Ramakrishnan, and Dr. Jay Ranganathan sir for a very beautiful session we are going to have. And everyone known is known in the pediatric cardiology group and everywhere in the all across the India and the world. So I don't waste much time on the introduction, and I think we should move. And it will be very delightful to listen to Anita Madam for approach to congenital, cyanotic congenital heart diseases. Over to you, Madam.
Thank you very much to Ajanta and of course to the course master Dr. Dheeraj and yourself for starting this particular session, which is basically meant for our TM and DRNB students in training. And I think they all are going to get at least one case, whether long or short, which will be a cyanotic congenital heart disease. So my talk will be primarily tailored towards the exam as to how to approach such a patient. And I will briefly, obviously, touch upon the various diseases that are grouped under this heading and how to go about uh, making a diagnosis. Of course, it will be mainly clinical and we wouldn't be touching upon echocardiography. So, cyanotic congenital heart disease can present at any age. However, the complex ones tend to present much earlier, for example, transposition, and the relatively less complex ones present later. The two classical diagnoses in adults would be tetralogy of Fallot and Eisenmenger syndrome, which we continue to see because of delay in the treatment. Obviously, the three tripods of clinical examination are history, physical examination, X-ray, and ECG, which are kind of part of our clinical workup. Now, how do we classify them? Conventionally, we say with pulmonary stenosis, and the classical example being tetralogy of Fallot, with pulmonary artery hypertension, and the classical example will be increased pulmonary blood flow. And I mean, the example is complete transposition. Tetralogies can present at any age, depending upon the severity of obstruction to RV outflow tract. However, those who are cyanotic and have pulmonary artery hypertension tend to present much earlier in very early infancy. And in fact, if not treated in time, majority of them would not survive their first birthday. The other group that comes up more later, let's say in second decade or so, are Eisenmenger syndrome, where a large shunt has been left unattended, unintervened, and over a period of time, their pulmonary vascular resistance goes up and they develop something called Eisenmenger syndrome because of the reverse shunting across the shunt. Uh, Pulmonary venous hypertension is rather rare, but must very, very sick patient. These are really babies who wouldn't even live for first 28 days or so. The classical example being hypoplastic left heart syndrome and obstructed TAPVC. And finally, we have something called Epstein's anomaly, which you all are familiar with, where the pulmonary artery pressure is normal, pulmonary blood flow is mostly normal, but may be reduced because of right to left shunting. Now, when we talk of adults, I think we can take away the second group of increased pulmonary blood flow with pulmonary artery hypertension, and we can also take away the group with pulmonary venous hypertension like HLH or hypoplastic left heart. So primarily we are left with tetralogy of Fallot or it's one of its allied conditions, or Eisenmenger syndrome or Epstein's anomaly, which can present at any age. But we are also added, or let's say another disease that is added in this group is severe pulmonary stenosis, where you may have right to left shunt at the atrial level. Some people like to call it triology of Fallot, and patient turns blue because of the right to left shunting. We could also, classify these cyanotic heart disease into basically whatever I said earlier can be grouped into these four headings: unoperated, which is tetralogy, is univentricular hearts; inoperable, which is classically Eisenmenger syndrome. Now we are getting another breed or another cohort of patients who have been intervened in the past, and this is really increasing. Now we are seeing more and more adults into their 30s and 40s who have been operated in the past, either tetralogy, because we all know tetralogy surgery started much earlier, and therefore these patients are getting into their third and fourth decade, or some of them are actually in fifth decade also. Then we also have patients who underwent palliative surgery like shunt surgery or a banding surgery, and now we also have patients who underwent a definitive surgery, which was not really corrective or reparative, but these were univentricular heart patients who did not have anything better than a Glenn or a Fontan surgery. So now coming back to the approach, I think history still is very, very important and must be taken in detail. For example, timing of onset of cyanosis. And here obviously the history has to be taken from one of the parents. Even if patient is an adult, obviously he or she will not remember what happened during infancy. So if there is very early onset of cyanosis, that is classically seen in transposition of great arteries and pulmonary atresia almost on day one of life. But those who present later in second or third decade of life are likely to be Eisenmenger syndrome because they were left to right and now they become right to left. In tetralogy, you can have variable degree of cyanosis, but it is hardly present at birth in anyone. It usually develops later, maybe in first couple of months of life, and of course, in relatively stable patients who are so-called pink tetralogy, it may present much later. Whether there has been any change in the severity of cyanosis, it tends to increase in all of these diseases. Also, another important point is to ask whether this patient had some features of heart failure like feeding difficulties, failure to thrive, sweating during feeding, and so on, which are suggestive of heart failure. And again, they would point to to the diagnosis of Eisenmenger syndrome because they must have been large shunt, which has reversed now. History of squatting and cyanotic spells go in favor of tetralogy or tetralogy-like condition. Then, of course, one needs to know about syncope, seizures, whether any bradycardia has been noted, what was the antenatal history, what was the family history, and so on. Rarely, they just come because a murmur has been picked up and the cyanosis is so mild that it was not even detected. So on examination, usual general physical examination, look for any syndromic condition, like for example, tetralogy of Fallows tends to go with 22q11 deletion or DJOR syndrome as we call it. How are the pulses, whether there is a differential cyanosis or uniform cyanosis in clubbing. And nowadays we have pulse oximeter almost available to us, in the ward or in the physical examination where you can look for saturation, preferably in all four limbs, any features of heart failure. But remember, in adults, getting heart failure is rather unusual with cyanotic heart disease. It is likely to happen only when it's late in the course of the disease. So most of the patients, or most of the cyanotic patients who are adults, will not have features of heart failure. That's an odd finding. And of course, we go for situs, cardiac position, because we know in congenital heart you can have situs inversus, dextrocardia, and so on. How's the apex beat? Is there a left parasternal heave or not? That's a very important, sign whether there's a left parasternal heave or not. Then how are the heart sounds? Especially we, bother a lot about second heart sound, if there's a click or not. And finally, murmurs. But remember to auscultate over the back because sometimes they could be collaterals and murmur may be also heard over the back. Another way we can sort of classify this is according to the presentation. I think two most common modes of presentations are heart failure and cyanosis. And in heart failure, you will see that practically the list consists of conditions which are seen more often in infancy and early child, or let's say early infancy, not so much in adults, except for maybe abstinence and pulmonary stenosis with RV dysfunction. As far as cyanosis presentation is concerned, again, tetralogy of Fallows comes right on top, although there are many other conditions, including Eisenmenger syndrome under this heading, or it could be incidental discovery of a murmur during one of those, medical board examinations or school examinations. There could be severe chest pain in some conditions, or even syncope, which may suggest severe pulmonary arterial hypertension. And in some of the newborns, you can have something called a cardiovascular collapse because of cyanotic heart disease, which are dependent on the ductus arteriosus. So when we are approaching a patient of cyanosis, I think the most important factor that will determine what diagnosis are we dealing with is the age of the patient. And of course, if there are any syndrome, because we know certain syndromes occur with certain specific congenital heart diseases. So let's come to neonates and infants. Same conditions in the heart failure, that is pulmonary artery hypertension with large flow, transposition, TAPVC, or lots of T's over here, tricuspid atresia and so on. But when it comes to cyanosis as a presentation, then Fallows again becomes the most common lesion. Please do not make a diagnosis of Eisenmenger syndrome in this age group because it develops much later. And of course, if it's a newborn, you have to think about ductus dependent congenital heart lesions, for example, pulmonary atresia with VSD or hypoplastic left heart syndrome. How do we differentiate the one with reduced pulmonary blood flow compared to with increased pulmonary blood flow? Usually it is easy because you will have history of heart failure in transposition physiology, but you would not have any heart failure in tetralogy of Fallows. There could be history of squatting and spells. And on examination, we are likely to hear a good systolic murmur in tetralogy, whereas you hardly hear any murmur in increased pulmonary blood flow. If at all, you may hear diastolic murmurs because of flow, which are relatively soft and may be difficult to appreciate. X-ray, of course, will show oligemia and no cardiomegaly in tetralogy, cardiomegaly and plethora in the TGA group. Also, as I said earlier, tetralogies can present at any age, but TGA and such conditions like truncus arteriosus, transposition, TAPC, they tend to present very early during infancy. Coming to older children, adults, you will see that most of the conditions that were producing heart failure in newborns or infants have gone away. You may have pulmonary stenosis critical or severe with RV dysfunction, which can present with heart failure. TAPVC, again, usually those who survive to this age do not present with heart failure, although it is one of the diagnoses from the earlier list. Presenting with cyanosis, again, tetralogy of Fallows, critical PA, sepsis and ambly, but you have added Eisenmenger syndrome in this group because in adults or in older children, in second decade, third decade, you may start to see Eisenmenger syndrome still prevalent in our country. Then, of course, PDA dependent lesions are out in this group. So Basically, two diseases which are common, Fallows and Eisenmenger, and that is where I think we ask a lot of questions as to how to differentiate tetralogy or Eisenmenger. How do you differentiate? If you look at the if you look at the pathophysiology, you will see that there is there is anatomic obstruction in tetralogy. So it is actually reduced pulmonary blood flow in both Eisenmenger as well as tetralogy of Fallows. But there is an anatomical obstruction across the pulmonary outflow tract leading to reduced pulmonary blood flow, and therefore pulmonary artery pressures are normal or lower than normal. On the other hand, in Eisenmenger syndrome, there is high pulmonary vascular resistance, which is at the capillary level. So pulmonary artery pressures are severely elevated. And again, a simple chest X-ray can give you the differential very easily. No cardiomegaly in both, but oligemia, pulmonary bay in tetralogy, RV kind of contour, whereas prominent pulmonary artery segment with dilated pulmonary arteries with pruning is the hallmark of Eisenmenger syndrome. Now, if you look at again the same features, how to differentiate between the two, you have no history of failure to thrive in infancy in Eisenmenger, whereas growth and weight gain is likely to be normal in tetralogy of Fallows. Three, or let's say, uh, one important feature is ejection systolic murmur. If you are hearing a good ejection systolic murmur in an adult, please do not make a diagnosis of Eisenmenger syndrome, because Eisenmenger syndrome hardly ever gives you a murmur which is more than grade 1 or 2, because there is no reason for a murmur in Eisenmenger syndrome. It's only the dilated pulmonary artery can give a bit of reverberations and a soft murmur. But in the tetralogy of Fallows, because we have pulmonary stenosis, therefore you are likely to hear an ejection systolic murmur. And we all know that deeper is the cyanosis, shorter is the murmur, milder is the cyanosis, longer is the murmur. But three features could be very helpful, that is syncope, hemoptysis, chest pain. They tend to occur very, or I would say far more frequently in Eisenmenger syndrome than in tetralogy of Fallows. So these features in a cyanotic will go or will favor Eisenmenger syndrome. These are some other findings that might help you to differentiate the various diagnoses within the cyanotic group. For example, if you have a prominent A wave in JVP, you might be dealing with triology of Fallows. However, tetralogy in adults, because of RV being very stiff and hypertrophied, may show a prominent A wave in the JVP. LV type of apical impulse is rather uncommon in any cyanotic heart disease, but if it is present, you have to think about tricuspid atresia or single ventricle of LV morphology, the so-called DILV as we call it, and very rare condition called DORV with restrictive VSD can also give you LV type of apical impulse in an adult. We always ask you to look for pulsations in the second left intercostal space. If there is levocardia, if there is dextrocardia, then we say okay, pulsations in the right intercostal space second, and that might indicate a dilated aorta, which is classically seen in corrected transposition or some of these single ventricles which have an L post aorta. Left parasternal heave is not a hallmark of any condition which has a large VSD, be it Eisenmenger syndrome or tetralogy of Fallows. So if you are getting a good left parasternal heave, that means your right ventricular pressure is more than left ventricular systolic pressure, and therefore you are perhaps dealing with a condition of severe PS with restrictive ASD or an ASD producing right to left, or you are dealing with a tetralogy where the VSD is getting restricted and therefore RV pressure is becoming higher than the LV pressure. Some other finding that can help you is if you are hearing, in addition to ejection systolic murmur, a pansystolic murmur of AV regurgitation, you might be dealing with AV septal defect, because we know that AV valves tend to be abnormal in this condition. Similarly, in corrective transposition, you may have left AV valve regurgitation giving you a systolic murmur which is more like a regurgitation murmur. Diastolic murmurs are unusual in cyanotic heart diseases, but if they are present, you might be either dealing with pulmonary regurgitation murmur, which is seen in Eisenmenger syndrome, but if it is more like an AR murmur, perhaps truncus arteriosus with truncal valve regurgitation. A seesaw murmur, which is typically systolic and diastolic, very superficial scratchy murmur, is the hallmark of TOF, absent pulmonary valve. In fact, TOF absent pulmonary valve is very easy to diagnose clinically because it is a very classical seesaw murmur. Bradycardia on examination or complete heart block on ECG might give you a clue that it is a case of corrected transposition of great arteries, or one of the heterotaxy syndromes where we know that CHP association is more common. And very importantly, if you have a patient who is significantly blue but also has a loud murmur, then tetralogy is unlikely. You have to think of a condition where there is reduced pulmonary blood flow as well as admixture, which is classically seen in TGA, VST, PS. So when the relationship between cyanosis and murmur is lost, you have to think of an additional, more complex congenital heart disease. As far as chromosomal anomalies are concerned, I think we are all very familiar that Downs is associated with AVSD. So if you have a tetralogy looking patient who has Downs, think of AVSD with pulmonary stenosis. Noonan's is more with PS. Williams, of course, you hardly will ever see them to be blue because they tend to have peripheral PS, which is may not be so bad. Congenital rubella can give you PDA PS. But what is often associated in cyanotic patients is this, which is DGeorge syndrome, which is associated with outflow tract anomalies like tetralogy or DORV or truncus arteriosus. This is often missed anomaly because the child may look very normal, but if you carefully look every child or every patient who has one of these outflow anomalies, you are likely to find many of more such cases, and therefore, of course, you need to go ahead and do some chromosomal studies to confirm. Just a couple of maybe 2 or 3 slides about TOF physiology. We all know it is reduced pulmonary blood flow because of outflow tract obstruction or pulmonary obstruction. And of course, you have this whole list of conditions which are also called TOF physiology. And I think in the exam we often ask you what are the conditions included under this heading, and you just need to remember the names. But basically, there are two key components: that there is severe obstruction to pulmonary blood flow, and there is a large non-restrictive VST equalizing RV-LV pressures, with the exception of tricuspid atresia, because we know in tricuspid atresia the RV is very small and the VSD tends to be small in them. So this is what makes tetralogy physiology. They have normal growth and weight gain. There is no history of heart failure during infancy. There is no cardiomegaly. JVP is not elevated. May show prominent A waves, but the hallmark is systolic thrill and ejection systolic murmur, which is in relation to the degree of cyanosis. X-ray chest typically gives you absence of cardiomegaly, upturned apex, pulmonary bay, dilated aorta, oligemic lung fields. This is typically called boot-shaped heart. But from the X-ray itself, you can sometimes look at the pulmonary arteries. Like over here, you are seeing LP and RP rather prominent. And you can also assess the sidedness of the arch. And you can see over here that there is an indentation from the right side. So this is the right aortic arch, which is seen at about 25% of tetralogies. If you have something like this, where your right heart bottle is almost under the sternum, apex is like LV type, ECG showing LVH, you're dealing with tricuspid atresia. If you have like a hump on the left cardiac border, but there's again oligemia, absence of cardiomegaly, you may be dealing with an L post or a single ventricle kind of situation. But if you have a situs mismatch, visceral situs and cardiac situs mismatch, like you have situs solitus with dextrocardia, or you have situs inversus with levocardia, or you have mesocardia, then you will be almost always correct if you make a diagnosis of corrected transposition of great arteries, which is very often associated with this kind of a condition. And of course, there will be L post aorta or L malposition in case of situs solitus. So an X-ray can give you a clue, but the basic feature is absence of cardiomegaly and oligemia. Then, of course, depending on the shape, depending upon the contour, you can try and make a diagnosis. But remember, these typical X-rays are not seen in all, they are seen in rather in minority of cases. ECG is extremely helpful. Right axis deviation, right ventricular hypertrophy, hallmark of tetralogy. But another good point to note over here is early transition. Early transition can almost certainly make it tetralogy of Fallot, but if early transition is not present, it can still be tetralogy of Fallot. Most cyanotic heart will give you right ventricular hypertrophy in ECG. If you see dominant LV, or if you see left ventricular forces, if you see absence of right ventricular forces, left axis deviation, then think of these conditions, which I also mentioned earlier: tricuspid atresia, hypoplastic right ventricle for other reasons, DORV with restrictive VSD, and single ventricle or DILV. This is a classical example of tricuspid atresia. Again, tricuspid atresia is one diagnosis where ECG is almost going to be always showing you these features, and you're going to be correct if you make that diagnosis on the ECG. Complete heart block, no PQRS relationship, bradycardia. Again, we have to think more in terms of CCTG, VSDPS, because CHB is often associated, or CHB is associated with that condition in some cases. I just show you this case, 28-year-old, diagnosed quite for some time, but now becoming more symptomatic. Not too bad a saturation. And if you just take history, then perhaps these are the diagnoses. He has never been intervened in the past, so we have to think of tetralogy, Eisenmenger as the two common diagnoses, and of course, others would be Epstein's and other rare diagnoses. Examination wise, he's quite comfortable. His saturation not too bad, 80% in all four limbs, and single second heart sound and a good systolic murmur. Again, giving you a diagnosis of tetralogy or tetralogy like physiology. Could it be Eisenmenger? No, because there is a good systolic murmur. Could it be an Epstein's? No, because S2 is single and apex is RV type. But there is something odd here, which is presence of heart failure. As I said, tetralogy patients are not supposed to have heart failure, but in adult tetralogy, you may come across occasionally patients who are in failure and therefore they become more symptomatic despite their saturation being almost what it has been for many years. So a common question that is asked in the exams, one of the questions is, what are the causes of heart failure in tetralogy or tetralogy physiology? And here is the list. I just want to emphasize here that don't make collaterals as number one cause. I have seen many students saying large MEPCAs is number one cause of heart failure. That's much less likely than the causes described above, which is of course ventricular dysfunction because of long-standing hypoxia. VSD may get restrictive, there could be increasing AR, there could be systemic hypertension, and so on. So there are many causes, but large MEPCAs is rather lower in the list. Now, another question that is often asked, why not triology or why not PSASD? Why PSDPS? Again, I think lot of points to talk about. JVP showing usually raised, showing prominent A wave. Left parasternal heave is a very hard point. If it is present, it is unlikely to be tetralogy. It is likely to be triology, as I said, because RV pressures become suprasystemic. You may be able to hear a P2 in triology, which is usually not the case in tetralogy or Fallows. Then, of course, murmur. Murmur and cyanosis are inversely related in case of tetralogy, whereas they are directly related in case of triology. You will have loud murmur and you may have significant cyanosis also. ECG will show you early transition RVH, whereas you may see strain in case of triology of Fallows. And again, X-ray is going to show you cardiomegaly with dilated pulmonary artery segment, because often this pulmonary stenosis level is valvular in patients of triology. It is infundibular in tetralogy, it is valvular in triology of Fallows. This is a 25-year-old lady who is presenting with mild dyspnea and fatigue. She does have minimal cyanosis. Again, features are like that of tetralogy. You have a single S2, but the murmur is very short, and you can see the X-ray where there is a prominent pulmonary artery segment, dilated right pulmonary artery at least, with pruning. So the likelihood is that she is suffering from Eisenmenger syndrome. Whether she can be pulmonary atresia because the murmur is very short, very unlikely, because generally they do not survive to that age, number one. Number two, her saturation is too good to be pulmonary atresia, it's 90%. If she was pulmonary atresia, she should have had a pulmonary base, she should have had large MAPCAs to produce that kind of saturation. So the next question is, what is the level of shunt? And for that, we tend to depend quite a lot on the second heart sound, which if single, we like to call it ventricular septal defect. And this is obviously based on the studies by Dr. Paul Wood and others, which have corroborated these physical findings. This is the echo, which is showing you slight right to left shunt. Obviously, her saturations are not bad, so you're not going to see much right to left shunt. Obviously, the question about pregnancy should be addressed because she's recently married, that she should avoid, or she should actually, pregnancy is contraindicated in Eisenmenger syndrome. The next question is, if you have made a diagnosis of Eisenmenger syndrome, whether it is at the VSC level or PDA level. Generally speaking, ASD Eisenmenger is very less likely because it happens specifically in some age, in females, in the age group of 20 to 40 or even higher sometimes. But it is VSD and PDA which are often confused together. If you can have differential cyanosis, and if you have measured saturation all four limbs, then I think there is no question. The diagnosis is very simple. It is patent ductus arteriosus, but then all PDAs do not show differential cyanosis. Second heart sound is supposed to be very helpful. Single second heart sound goes in favor of VSD. A narrow or a normal goes in favor of PDA, and a wide split goes in favor of ASD. Presence of tricuspid regurgitation is unlikely in VSD PDA because the RV pressure never goes, or PA pressure never goes beyond aortic pressure, so you are not likely to see TR. And EDM or pulmonary regurgitation favors more of PDA than VSD or ASD. So this way you can to some extent give a diagnosis whether it is Eisenmenger at VSD level or Eisenmenger at PDA level. This group, I think we don't hardly, or I would say we don't is not the right word, but we very, very rarely see in adults, because these are the patients who, if not intervened, will not go beyond the first year of life or so. And of course, they would have very early presentation. This is, very early presentation, hardly any murmurs, cardiomegaly, heart failure, diastolic flow murmurs may be heard, and X-ray will show you cardiomegaly in plethora. And I just want to show you this exceptional, I would say, survivor, an 18-year-old girl who came with deep cyanosis, no murmur, and our first diagnosis was obviously Eisenmenger syndrome, but her cyanosis was rather deep for Eisenmenger to be of comfort. And then we looked at her echo, and she actually had transposition of great arteries. Her pulmonary arteries are rising out of the left ventricle, which is bifurcating, and the aorta is coming out anteriorly from the right ventricle. I know this is kind of reverse image for many cardiologists who are practicing adult cardiology, but as pediatric cardiologists, this is what we like to do because this is the anatomical position of the heart. What was making her go through or live till this age is large ASD. In fact, there are two ASDs, as you can see. So occasionally you may have a case which is not falling into tetralogy or Eisenmenger group, but these are really exceptional survivors and we don't often see them. Another condition that you may see in adults is total anomalous pulmonary venous connection, which almost behaves like an ASD in them, except that they are little blue or they are mildly blue, and their X-ray may give you a clue that this is actually not an ASD. This is supracardiac total anomalous pulmonary venous connection, typical figure of 8 appearance. And finally, I think maybe one or two more patients. 15-year-old boy presenting with palpitations, sinus not much, but there is no heart failure, and a widespread second heart sound. So if you have a widespread second heart sound, what are the various diagnoses? This is the list of conditions which have cyanosis and a widespread second heart sound, because most of the other conditions will have a single second heart sound. And you can see majority of them have ASD as the underlying disease. And then of course with ASD they have a widespread second heart sound. So this patient had an X-ray which was showing a gross cardiomegaly, huge RA enlargement, as you can see. ECG is quite typical of Epstein's anomaly with an RVBB kind of morphology with no RVH, and it is like one QRS attached with another one, which is classically described for Epstein's anomaly. Cyanosis with normal cardiac examination, normal split second heart sound, no murmur. Think about these conditions. They are relatively rare, except pulmonary AV malformation, which we do see from time to time. And there are several causes of AV malformation, but nowadays we have started seeing these malformations in post Glenn procedures. So patients who have undergone Glenn procedure in the past for single ventricle may come back with pulmonary AV malformation. Very easy to diagnose, just echocardiography with saline contrast can give you the diagnosis. Sometimes X-ray can be helpful in big AV malformations like this X-ray is showing. So this is actually just to show you that you are likely to see more and more post-operated cases now who may have undergone some surgery or some intervention in the past. This was a case of actually single ventricle and underwent BT shunt first, then Glenn at 5 years of age, and then came for follow-up several times but was found to be not suitable for a Fontan surgery because his pulmonary arteries were rather small. Saturation is quite low, as you can see. He has had several AP collaterals embolizations in the past. So what are the causes of hemoptysis in this condition? Of course, AP collateral is on top, but you can also have pulmonary AV fistulae following Glenn procedure. And actually, he had several AV fistulae and underwent multiple vascular plug closure for these, which will at least ameliorate or alleviate his cyanosis to some extent. So these are palliative procedures, of course. So in the end, I would just like to sort of summarize that if you have a patient who's cyanotic, age is very, very important. And the second most important feature is whether there is congestive heart failure or not. In neonates, that's not an unusual condition like transposition, TAPVC, etc. And of course, if there is no CHF, then tetralogy has to be thought of, which is still the common condition or very common condition even in infancy. In older children, again, CHF not present, ejection systolic murmur present, tetralogy, but rarely you may have a patient in whom there is CHF, and then of course you have to think about conditions. which are causing heart failure, whether it is tetralogy with some complications or it is severe PS with RV dysfunction. Older children, adults, again, no CHF, tetralogy, and Eisenmenger syndrome. But if there is CHF, then you again have to think about rare conditions where there is a complication with tetralogy or patient has gone on to a stage where his ventricular function has become very bad, as happens in their 40s and 50 years of age with tetralogy or with Eisenmenger syndrome. But of course, further tests will be required to confirm the diagnosis. So, adult single second sound, good systolic murmur, TOF or TOF physiology, single second heart sound, but hardly any murmur, at least not a systolic murmur, Eisenmenger syndrome, quiet precordium, multiple sounds, abstinence anomaly, ASD findings with bitrix split with ejection systolic murmur, tricuspid flow murmur, but the child or the patient is slightly blue, you can think about TAPVC, which is not so uncommon in adults. We do see from time to time. Thank you very much for your attention. Happy to take any questions.
Thank you very much, madam. Very illustrative and insightful lecture from you on approach to the cyanotic congenital heart diseases. I think not only the students, but we are also got a lot of learning in this session. If any comments or any desirable comments from the other faculties are welcome, or otherwise we can proceed to the lecture. I think it's 9 o'clock. We can proceed to the case presentation.
Charan sir, I cannot see any questions in the chat box coming from the PGs. As and when it comes, I'll drop it down in the chat box. We may go to the case now. Thank you.
And one message from Dr. Ajay Mahajan. He's sent his apology that he couldn't attend today's class because he was traveling. So thank you very much all the faculties and the student for attending this presentation. Thank you. So who is presenting for today's case?
Dr. Charan, there are two students from Jaideva.
Right, sir.
One is Dr. Subhash. He is a resident in DM Pediatric Cardiology, Subhash Chetri. He is a second year postgraduate. The second one is Dr. Yash Sharma. He is a DM resident in Adult Cardiology. Okay, so they have taken two cases. Both are cyanotic, I suppose.
Right.
The cases have been given and prepared by my colleague Dr. Priyadarshini, who is assistant professor with me. I think she has all the data and the ECG, X-ray, echo and angio. She is going to present from her laptop. I think we'll ask Dr. Subhash to start with the case first, and then we'll ask the faculty to interrogate Dr. Anita Saxena ma'am, Dr. Rama, and of course you are there, and we'll all take up the discussion. Dr. Subhash, are you ready?
Yes, sir, I'm ready. But am I audible?
Yeah.
Yes, you are audible.
Yes, sir.
So
Sir,
please
shall I
start.
present?
Yes, share the screen.
Video.
Have you prepared the PPT?
Yes, sir.
Yeah. Hello?
Sir, I am presenting on paper.
Oh, okay, it's fine. You have not prepared this one.
No, sir.
Okay, present then. Yeah.
Our patient is an 18-year-old girl, Nandita, from Hubli. Informant is mother and the child, and they are reliable. The patient presents with the history of bluish discoloration of lips and tongues since early childhood and fatigue since early childhood. Since the history started from early infancy, I want to present from the birth. She was born as a first child to parents with non-consanguineous marriage, as full term with normal vaginal delivery with average weight at Kim's Hubli, and she was well at birth and was discharged at day 3 of life. At around 20 days of life, mother noticed bluish discoloration of lips and tongue, especially on crying. She was taken to a local pediatrician and was referred to Kim's, where she was admitted there for 1 week. At that time, cardiac scan was done, and she was told to have congenital heart disease, in which she was told like one side of the heart is not well developed compared to the other side. and she was told that she will need multiple stage surgeries. At 4 months of age, she underwent surgery from left lateral side, which occurred at Occard Hospital in Bangalore, following which her bluish discoloration improved. She was told that this was temporary surgery and she will need another surgery in near future. Uh, After the surgery, mother noticed that her bluish discoloration improved, and but also she was told that at 1 year of age another surgery was needed. So at 1 year of age another surgery was performed, but this time from the midline incision. Following these two surgeries, she didn't have bluish discoloration, and she was not put on any medications. According to the parents, her afterwards there was no episodes of suggestive of opposite or suggestive of cyanotic spells. However, she was less active compared to her peers during the play. Uh, the parents have not noticed any squatting episodes. Um, for the last 15 years, she is being following up regularly to the cardiologist. She was told that she will need a third surgery, but she was asked to wait. But for the last 2 to 3 years, she was noticed to have increased fatigue. Initially, it was class 2. Now, for the last 6 months, it has been class 3. Uh, in the infancy, there is no history suggestive of suppressed subcycle, growth rating, intermittent feeding. In the past, there is no history suggestive of syncope, palpitation, breathlessness, or leg swelling. Parents have noticed that she is lean and thin compared to other children, but there is no history. But there is no history of stunting, no history of headache, vomiting, altered sensorium, seizures, no history of fever. Currently, she was told that she needs a third surgery, and to prepare for third surgery, she needs a procedure for which she was admitted, and she underwent a procedure from the left groin. That was on Tuesday. She was told that after the procedure or what type of surgery to be done, whether it is needed and all will be told. Past history, she was not admitted for any other hospital, any other reason other than these two surgeries. Vaccination, she is vaccinated up to date, not put on any medications. She is developmentally normal, currently studies in 12th standard in humanities with average scholastic achievement. Family history, there is no family history of heart disease. Father had deep vein thrombosis for which he was operated 2 months back. She comes from non-consanguineous marriage. Non-consanguineous marriage. She is the first of the two children. Second child is 14-year-old male. Uh, Social history, according to modified Kupuswamy scale, she lives in. She is a lower middle class. She lives in a pakka house, 2 room including kitchen. There is no history of exposure to any smoke, including kitchen smoke. Sir, this much history. Summary: an 18-year-old girl with history of cyanosis since neonatal period, for which two palliative surgeries was done, and now she is brought with fatigue for the last 2 years, which has worsened in last 6 months. She was admitted for cath study prior to her third surgery.
So, can you explain why third surgery has been delayed for so long? You are saying she's under regular follow-up.
Hmm. Sir, according to the mother, what she is saying is she is regularly following up, and the doctors told her that third surgery she has to wait. She was told that her oxygen level in the blood is enough for now. That was what she's told.
Okay. So, can you think about the various possibilities based on the history only?
Sir, the thing is, she has been categorically telling that she has been told that all the surgeries are palliative in nature. So what I think is that the it would have been like it is basically it is a cyanotic heart disease with decreased pulmonary blood flow. So because she has told that surgeries are palliative in nature, I feel that conditions other than TOF are more likely.
Like,
Although TOF is also very high in the list because of the its incidence. Then other conditions with decreased pulmonary blood flow like tricuspid atresia, single ventricle with PS, uh, CCTZA VSTPS,
so
TZA
why
VSTPS.
can't it be increased pulmonary blood?
No, first is she has given history of cyanosis, which was her major complaint. Number
So
two, there is no history suggestive of failure in infancy. Like if there is increased pulmonary blood flow, there should have been history of failure, like suppressed subcycle growth sweating, intermittent feeding, history of recurrent hospitalizations for LRTI. Those histories are not there.
So if that history is not there, can you rule it out completely? Because she's 18 now. I don't know how much of her, how much her mother remembers of that period. Is there any other way you can say that it is not large flow?
The first surgery was done at what age?
First surgery at 4 months. So
Okay.
yes, sir. Second surgery at 1 year.
So the
If I
first
say
surgery was
she underwent a
Uh,
PA band at 4 months of age, how do you counter it? You said one that she had no history suggestive failure. That point is well taken. Anything else that can tell you that it was not a band?
there should be some history.
Do we have another student? Another DM candidate?
yeah, we have another yes, Sharma.
Yes,
So would you like to contribute? Supposing I say this is PA band at 4 months of age, and she had something like a large flow, something like transposition physiology with a VST. Can you counter me that no, it is not? I'm not able to hear you.
Your connection is not good.
sure. Am I audible, sir?
I think your connection is not very good. Not able to understand what you're saying.
Sure,
You can put it in the chat box if you wish.
sure.
Dr. Subhash, any idea?
No, man. Only I felt ki it is like condition with decreased pulmonary flow because of the her symptoms were primarily cyanosis initially, now fatigue, and her
No. First day, what was the presentation? When the child was in neonatal period, did the parents give
cyanosis,
any cyanosis? What was the
cyanosis,
degree of this cyanosis? Was it severe?
degree.
Was it severe or was it anything? Any idea did they give about that? Or I'll give you one more clue. The 4 months, how commonly we do refer at the age of 4 months the PA banding? What is the generally
List like
90% of or 95% of our PA bands are done at what age?
1.5
Except
to
in a cyanotic heart disease I'm talking about. I'm not talking about the conditions like the multiple muscular VSTs. No, in a general cyanotic heart disease with increased pulmonary flow, what is the recommended age of a PA band?
by 2 to 3 months we have to do.
What is the outer limit of you want to do a Glenn in a patient? What is the outer limit of the accepted time? 3 months is too late.
Sir,
You're talking about, we do talk about months or weeks?
Weeks, sir. We
Yeah,
do
then
in
what
weeks.
weeks? Second week, fourth week, which week we do?
By 4 weeks, vascular resistance comes down. By the time we have to do 4 to 6 weeks we have to do.
4 to 4 to 6 weeks or 4 to 8 weeks?
I think the hardest point over here is that you said the patient's cyanosis improved. Patient
Yeah, that
cyanosis
was
does not improve after a PA band. It actually
Power
worsens
on. Get
unless they
ready to
would have
go to the future. Bluetooth mode. Your device is ready to.
unless you have done a septectomy or something along with it, which you will not be able to do from the side because she underwent surgery from the side and her cyanosis improved. There is no other
Yes, sir.
diagnosis but a aortopulmonary shunt. Also, a lot of people don't like to do a PA band from the side; they would rather do it from the midline. So, I think both these points are, especially improvement in cyanosis is very unlikely after a PA band if you have not done a septectomy or something along with
then
it.
it is not a band at all. Then it's not a proper band.
Yes, and
It's
then
not
you
an
do it
effective
from the
band at all.
midline. Anyway, you do it from the midline.
So Ashok, I think another most important point also is history wise. Typical history in very 15 to 20 days, your patient had a appearance of cyanosis, which is I think it required an palliative surgery. So none of the case I think it has to be a decreased pulmonary flow in that situation. That history typically present that and a number of palliation occurring. Also the second point where you could think of these differentials.
So, Dr. Subhash, one question is that suppose if it is a typical, say, shunt followed by a Glen, is it a normal story like you don't do a Fontan later? What are the situations you don't do a Fontan later? Like patient is under regular
Suppose
follow-up. Last to follow-up, we don't know like what there could be many reasons the patient doesn't come that you can't do. But patient who is regular on follow-up, so what are the situations in which you don't do a Fontan?
suppose there is a condition like interrupted IVC where Fontan is not done in single stage, like condition like interrupted IVC.
Okay.
But she has been told that third surgery also will be needed.
So that is not the case. So what are the other situations where suppose you evaluate a patient and you say okay it's not possible.
Maybe saturations has been good.
Since it is a normal story, like you do a Glen in a 1-year-old, do the saturation remain all right for 18 years?
No, no. Usually by 4 to 6 years we do Fontan.
No, but 4 to 6 years. What is the current international standard of doing Fontan? At what age Fontan is done nowadays, and why it is done early?
And 2 years also we can. Lowest is 2 years we can do.
I think
Why people have moved
just
on to 2 years now?
Big,
I think other student also can reply these questions if other person can try the.
one more thing is for if there is chronic hypoxia, there may be some subtle neurological issues in the child. And now because
more importantly, people realize that obviously, as you said, that oxygen saturation is far better in Fontan. The more importantly, the ventricular unloading is better with the Fontan, early Fontan. So the otherwise the ventricle is handling twice the load. So that is unloaded better, and the overall people think that possibly it is longer. And as you said, in India we have been doing Fontan at around 4 years, but Western countries have moved to around 2 years. So the other issue is that any other possibility apart from single ventricle pathway in your patient, like
Before that, I want to ask: is there any downside of doing it early? Are you doing pediatric cardiology or adult cardiology?
I am a pediatric cardiologist.
Then you should know it. Is there any downside of doing it early? If none, then why are we not doing it early?
The Fontan is also like it will also it has its complications like plastic bronchitis. All those complications will occur, and if we do early, the time period of occurring that complication becomes earlier.
Yeah, so you're absolutely right. I think the duration of Fontan is very important. It is kind of limited. So if you do it early, that is the duration you have.
So the
Sorry.
major important is not plastic bronchitis and all. Most important thing is liver problems like. So they are the ones that are limiting. So some other question that possibly I think for the benefit of the audience that we may be answering. Like one of the thing is like what are the other situations where you seen a Glen patient and you're not going for a Fontan, that could be related to primarily PSIs. PSIs is not very good for a Fontan, or if there is a PA pressures have been catheterized and PA pressures are like more than optimal. So some of these situations are generally like that could be the case because saturation is all right. So maybe the PA pressures are on the higher side, and the treating physician felt that she's a high risk Fontan and she's doing well. Let's wait. But generally, at what age is the glands lose the saturation like, or have suboptimal saturation?
3 to 4 years of age.
So at what age upper body, lower body proportion of blood flow, blood supply changes? At birth or at younger age group, at what is the upper body, lower body blood flow, and what happens over time when the
At
transition
younger
is
age,
complete?
at younger age, it
So
is
that's a very important concept to have, and generally by around 6-7 years, the reverse happen, and blend is alone is not sufficient to maintain saturation in most of the patients.
What are the different criteria for doing a Fontan, Ashok? After the Glen, I think that's a major question. Hello. I think he's lost the connection. Subhash.
yes, sir.
So what are the criteria for fulfilling for the Fontan? After the Glen, suppose you want to the Fontan, what criteria will fulfill, and how do you do that?
For Glen pressure, we do first before the Fontan. We do
That's a diagnostic
diagnostic cath study in which we see that first is other than the PSIs, Glen pressure should be good.
I think Dr. Rama has already told you about the end diastolic pressures and function.
So another basic question is, out of the 10 commandments, how many commandments are important in today's time?
Nowadays, yes.
Glen pressure is very important. Sir. Glen pressure, pulmonary artery sizes.
So what are the most important two things?
Diastolic.
One is anatomical, another physiological. The rest of the thing you can manage.
I think
so. Low PVR, there should be good pulmonary artery development, no significant outflow tract obstruction, and good systolic function, as we just said.
so. From your coming back to your case, can you tell us your first differential diagnosis? You couldn't make it. You said it probably is not a tetralogy of Fallot. So what is the first possible you want to make any choice?
Sir, it can still be tetralogy of Fallot with the pulmonary atresia, in which first BT shunt was done, and then like stage surgeries they have told.
No. How can it be pulmonary atresia? Stage surgery, her cyanosis has not gone away. It has improved, but it hasn't gone away, no? That's what you said. So what is the surgery done at 1 year of age, you think?
That I think is Glen.
So then, do you do Glen in VSD pulmonary atresia?
No.
So basically you want to say single ventricular physiology, right?
Yeah, mostly single ventricular physiology only.
Okay.
So other than...
So what are the single ventricular physiologies for which you cannot do a two ventricular? Like one is of course tricuspid atresia and second is single ventricle itself. Could there be other reasons for not able to do two ventricle repair? Okay. All right. Anything else?
Corrected TJ with like any condition with large VST with PS.
No, you can do it. You can correct it. You can do two ventricle repair. I mean, obviously, two ventricle repair is always preferred to single ventricle repair. So, as far as possible, surgeons would always want to do a two ventricle repair, but there are certain situations where you just can't. So besides single ventricle besides real single ventricles. Your friend is not helping you.
In any of these like TCA, VSTPS, or CCTCA, VSTPS.
So why would you do Glenn Fontaine in them? You can always do
in
two
which
ventricle
one
repair.
of the ventricles is underdeveloped.
That is okay.
Uh,
That is done. Unbalanced condition where one ventricle is actually small. But if you have two good sized ventricles, is it still possible not be able to do two ventricle repair?
So I'll give you a clue, some kind of a DORV.
it is if it is not rootable.
Yes, that's another important. Although surgeons try and do all kinds of things to make it root LV to aorta, but there could be some conditions where the PST is absolutely non-committed. It is somewhere remote and you just can't root it. So those are also sort of done in the same way, Glenn Fontaine, but then actually they're not single ventricles. So I think your diagnosis is pretty obvious based on your history because her two surgeries have been done and she's due for another surgery and her cyanosis never gone away. If you had said that cyanosis had gone, one could have thought of pulmonary atresia with a conduit which needs a replacement. That also is a multiple surgery, it's not multi-stage surgery. Okay, if there are no more questions, we could go to the
So
exam.
one question, just ma'am. Why do you think there is a fatigue? You said it is a class 2 fatigue increase to class 3 recently. What is the reason in this patient? Subhash, Dr. Subhash.
Maybe now the brain has not become like, as she is growing, the brain is not enough to support the demand of oxygen demand of the body. So that's why fatigue is increasing.
Generally, what is the means? Why do you get fatigue in a congenital heart disease?
It is when there is a decreased pulmonary blood flow, those type of situations, like
Increase pulmonary blood flow.
decreased.
Decreased pulmonary blood flow. So, in all decreased pulmonary blood flow, you will have the fatigue situations. Fatigue is, can it be, I mean, in any congenital heart disease, more fatigue is more concern about if it's not a cyanotic, the cardiac output related, right? Exertional, if there is decrease in the cardiac output, then it is a fatigue, right?
If there is a PS, like not in this case, if there is a PS,
yes, fixed obstructions or those cases.
or in case, not in this case, if there is Eisenmenger physiology, there is also fatigue is a prominent symptom.
Okay, I'm not sure about this fatigue, and you have classified also to class 3. So by which criteria it is class 3?
WHO, sir.
WHO. So how do you define WHO class 3 fatigue?
So it's similar to that NYHA, where but thing is, first class 1 is extraordinary activities, class 2 is less than ordinary, class 3 is ordinary, and class 4 is at rest.
Prabhas,
So-
why do you use WHO here?
Because in NYHA fatigue is not there.
What?
Why are you bringing a WHO, man?
When WHO is to be used?
Tell us why. You're mixing up the two.
I think it is to be used in PH situation.
Yes. Oh God.
I think we can go to the examination, I guess, isn't it?
Examination, she is thinly built, poorly nourished, pulse rate is 71 per minute, regular, no radio.
Sorry, I just wanted to, sorry to interrupt. Fatigue is also part of NYHA.
It is a part.
So why did you? I don't know. Yeah, why should you bring in? Why should you bring in WHO? WHO is not for this, and fatigue has NYHA, so you should call it NYHA class 3 fatigue.
Okay, ma'am. Examination, she is thinly built and poorly nourished. Pulse rate 71 per minute, regular, normal volume and character. No radial, radiofemoral delay. All pulses were felt. Respiratory rate is 14 per minute, thoracoabdominal. Temperature 98.6 degree Fahrenheit on axilla. SpO2, the blood pressure, right upper limb is 110 by 64. Lower limb is 116 systolic. SpO2 upper limb, right upper limb is 74, lower limb is 71. JVP 8 centimeter above sternal angle, prominent A wave is seen. Central cyanosis present, pan digital bed 3 clubbing is present. No icterus, lymphadenopathy or edema. Head to foot examination, no facial dysmorphism. She has dental caries, no cleft palate. There were bandage on neck and groin, no hematoma, no bruise. This bandage was after the procedure. IV line on the left dorsum of the hand. Healed pyoderma scars on the bilateral lower limb was present. Limbs and digits normal. Anthropometry, weight is 32 kg, less than third centile. Height is 152 centimeter, 10th to 25th centile. BMI for age is 19.2, less than third centile. Cardiac examination, inspection, midline sternotomy and thorax.
So Dr. Subhash, I think before we go to cardiac examination, I think you need to clarify the JVP. Again, can you come again? Like, what is the JVP like?
Sir, JVP 8 centimeter above sternal angle and it prominent A wave, right sided JVP.
No, is it elevated or not?
It is elevated.
So you should first say elevated.
So what happens to JVP in a Glenn?
In Glenn, it gets it is not in the relationship with the RA. So JVP will be elevated.
So will it be pulsatile? Will it be pulsatile? If at all it is pulsatile, what kind of pulsation will be there?
It will be more phasic.
It will be more hazy.
It won't be pulsatile. It will be more phasic based on.
So how come A wave come there? Like, suppose if it is Glenn.
What do you mean by phasic? You mean
in
systole and diastole?
JVP decreases, in expiration JVP increases.
No, that's a separate issue. Right now you're being asked about the waves. Will it have ACV waves, X and Y descent or not?
No.
No, listen, what is Glenn? Can you tell me what is the communication in Glenn?
When we connect the SVC to the pulmonary artery.
Pulmonary artery. So venous connection to the pulmonary artery. What is the PA pressure generally?
Sir?
What would be the pressure, PA pulmonary artery pressure in that patient? Just imagine, it will be more than the venous pressure at some moment, right? So there will be some arterialization of the venous pulsation, no? There will be raise in the JVP, right?
Okay. Pulmonary artery pulsations will be transmitted.
Only thing is, if there is no antegrade flow in the pulmonary artery, like most of the people would tie up antegrade flow at the time of Glenn, then you would not. In fact, the PA pressure will look like SVC pressure. PA pressure will show you a V waves in a Glenn, unless the antegrade flow is open. Dr. Rama, you want to comment?
Yeah, like basically, you don't find the classical A wave and V wave and all those things are not found.
Yeah, but you do not have systole diastole also.
Yeah.
Yes, like it's like
it's like almost like a flat line, with a little waviness.
With some phasic variation, and there is nothing like a systolic diastolic variation. Like,
in fact, the PA pressure will also become like a venous pressure. Okay, go ahead. So you can actually assess the PA pressure or the SVC pressure by the level at which SVC is.
Cardiac exam, inspection, midline sternotomy and left lateral thoracotomy scars are present. No bony deformity. Chest wall bilaterally symmetrical. Apical impulse medial to midclavicular line at around intercostal space. No other visible pulsation. Palpation, apex beat is felt at left fifth intercostal space, 1 centimeter medial to midclavicular line. It is LV apex. No palpable thrill, no heave. Percussion, liver dullness at 6th intercostal space on midclavicular line. On right, left, 5th intercostal space. Left second intercostal space is resonant. Broad space is on the left. Left heart border corresponds to apex, right heart border 1 centimeter lateral to the right parasternal area. Auscultation, S1 is normal, S2 single, only A2 is audible, no audible P2. No additional sounds, no murmur.
So absent P2, right?
Per abdomen, liver 1 centimeter below right costal margin at midclavicular line. No spleen palpable. RS bilateral normal vesicular breath sounds. CNS no focal neurological deficit.
No murmur anywhere.
Sir?
Any murmur?
No murmur.
Power on. Get ready to port to the future. Bluetooth mode. Your device is ready to pair.
No.
Okay, so what?
Diagnosis?
Congenital heart disease, cytosolitis lipocardia with congenital heart disease with decreased pulmonary blood flow. Probably tricuspid atresia post BT shunt and Glenn in sinus rhythm, not in infective endocarditis.
No heart failure?
No features of heart failure.
Can you describe the apical impulse again?
LV apex, sir. So it is apical beat felt at left fifth intercostal space. It is LV type of apex.
How do you make out LV versus RV apex?
LV apex is more RV apex is more diffuse, and LV apex is more localized.
What else?
Circumferential and lateral contractions.
Anybody else wants to add, like Dr. Yash, what are the differences between LV versus RV?
So one is the LV type of effects will be localized. RV will be more gentle diffused. Second would be the location. The LV type of effects would be in the left fifth intercostal space. RV type may be in the left fourth or fifth or subxiphoid. Second is the retraction. LV type of effects, medial retraction. RV type of effects.
They're both basic, na? Like LV goes down and out and RV goes laterally. So generally whenever there's dilatation, that is the thing. So I think that you are connected to two devices. I think that's why echo is coming. So number one is the location, like where is it located? It is either down and out or outwards. RV versus LV. Localized, like almost LV is like a ping pong ball coming in between the rib cage and comes and touches and goes. So RV is generally more diffuse. So what else is there? And generally the RV apex will be continuous with your, and then retraction is very important. And apart from retraction, the other important point is RV apex will be continuous with the parasternal heave. Whereas if it is LV forming the apex, there will be a retraction in between. So what are the other conditions producing LV apex with cyanotic congenital heart disease? Pam has listed out the possibilities. So what are the possibilities?
Single ventricle with LV morphology. Hello?
Yeah,
Hello?
yeah, go on. Go on.
TGA VSTPS.
Why TJVSDPS? Why LVFX and TJVSDPS? In TJ, what is the systemic ventricle?
Systemic is RV. Systemic ventricle is RV.
Okay, what else?
AV canal defect with VSTPS.
AV canal defect with VSDPS. Why should you have LVFX? LVFX is very specific. Now, like what are the conditions that can produce LVFX? There are some conditions under tetralogy physiology. There are some conditions without tetralogy physiology. But yes, you want to come in? Anybody wants to put it in the chat box? What are all the conditions that can produce LVFX? Ma'am actually told in all the
Ah,
in
it has
your
been
lecture.
presented in the madam's lecture only. All LV apex and cyanotic congenital are.
Anything in the DORV type? One type of DORV. Madam has written that in her chart.
DORV with subpulmonic VSD.
No.
Behavioral supplementary VST will behave like what? Like it's like behavioral like
TGA,
TGA,
sorry,
na?
it will behave like
TGA,
TGA.
yeah. So it is restrictive VSD. DOR with restrictive VSD. Non-tetralogy physiology with LV apex. Cyanotic anal heart disease. Non-tetralogy physiology with LV apex. Classical.
Like aspirators.
Non-pathology.
Respiratory is already said, no?
Yes, sir.
So it is Epstein's anomaly and intact septum pulmonary atresia. So whenever you are asked like this, it's very simple. Now, like most of these conditions producing cyanotic anal heart disease are right-sided problems.
Right side.
And you are saying something which is left side is prominent, LV is prominent, your patient is cyanosed. So you have to immediately think of conditions either the LV is super dominant or RV is hypoplastic. These are the only conditions that can produce.
Why do you say it first is a British shunt and then the Glen shunt has been done?
Sir, thing is like because of the symptoms, it looks like cyanotic physiology, and she has told that some surgery has been done which improved her symptoms. That is most likely to be a AP shunt surgery, and because it was a surgery, not a procedure, I feel it was a BT shunt. And lateral thoracotomy is done is one of the ways BT shunt is done.
Okay.
So shall we go to the investigations?
Yes, madam. Can.
Yes.
Sunny, I think how many cases we have? 2 cases, no?
Yes, sir. Yes, sir.
And our time allotted is up to 10 o'clock, isn't it?
Yeah, sir. We do have some time left.
So, so we will finish this case or we want to
Yes.
go with another case. Can you in the short tell us the positive finding in the ECG and
Sir, in the ECG, P waves look tall in lead 2, lead 2 and lead 1.
Subhash,
From
start
stand from
properly. Rate rhythm quickly. Go ahead with that. Rate rhythm
So,
axis.
no, it is a normal standard ECG with a rate of around 75. Rhythm is sinus. P wave is axis is 90 degree. P wave looks tall in 1 and 2.
Whereas axis is 90.
Axis is 90.
That's not right.
Sorry, axis is 0 degree.
Yes.
Perpendicular to ABF. It's 0 degree. Axis is 0 degree. Then in V1 deep S deep S is seen in V1 in V2. Actually all the leads it is.
Okay, talk about the loop. Also talk about any transition is there or not. What is the axis of
There is no transition.
So what does this X-ray? What does this ECG suggest? Can you think about
It
some
is,
specific
it also
diagrams?
suggests the LV forces.
LV forces, but P6 also has S wave. So it could be single ventricle, it could be DILV, something like that. So it's not typical of tricuspid atresia. And of course, tetralogy is out. But of the univentricular hearts, it could be single ventricle also. Okay, X-ray. I think let's quickly go to the next one.
Go to X-ray.
Yes, sir.
Why is P inverted in V2, V3, V4, V5?
X-ray, chest, AP view, PA view, sorry. It is overexposed. We can see the sternal wires, situs solitus, levocardia, LV apex. The LA looks slightly enlarged.
Really? I don't think so. Why do you say that?
Okay.
The bulge in the ear.
That bulge is not really LA. There's a hump, all right, but that may not be LA. That could be outflow tract.
Not actually, it is something some channel, no?
Is ascending aorta dilated?
Yes, ascending aorta is dilated and looks like.
Or could it be SVC? Because he has had a Glenn.
Yeah.
She has had a Glenn many years ago.
The indentation on the right.
No, we are not talking of the arch right now. There is a shadow on the right side, which I am thinking is SVC or aorta. To me, it's more likely to be SVC.
Look like SVC.
Why there is crowding of ribs on the left side?
Yeah, there is decreased crowding on the rib on the left.
Why? Do you know the cause? You
So when there is a crowding, what do you?
You said
What do
I
you call?
feel the pulmonary blood flow to that side is less compared to the other side.
Sorry?
Blood flow to that side is less compared to the other
No,
side.
blood flow
Post
doesn't.
surgery has been done, no?
Post procedure
You said no,
fibrosis.
left lateral thoracotomy. That is how it looks.
Okay, tell us about some pulmonary bay. Is there a bay or absent? What is it?
There's a decreased. It is looking at. Such a decreased pulmonary blood flow. Only 1/3 I am able to see the pulmonary vascularity.
It's not looking like a tetralogy X-ray because you have a bit of a hump over there.
It's not looking like
more like a univentricular heart, and there is crowding on it. There's clear oligemia, although it's a bit hard film, but I think there's clear oligemia.
Subcostal view, situs solitus, pulsatile abdominal aorta. Aorta is on the left, IVC is on the right. This apical four-chamber view. There is tricuspid atresia with large inlet VSD with mild AVVR, left AVVR. Yeah, mild left AVVR is there.
What is the obligation? You should explain that also, no?
Right to left across the ASD.
How is the function of the ventricle?
Good LV function. LV outflow tract, ascending LV outflow tract, there is no obstruction. There is no air.
What is the turbulence which is seen there? Yeah, your marker is there, yes.
There's some right, there's some left AVVR here.
Left AVVR? If you open it well, I think.
Is that pulmonary outflow?
Pulmonary arteries and bifurcation, no?
Let's see other views because it could be pulmonary outflow. It's like a DORV.
That is the pulmonary outflow, which is just to the left of the aorta. There is severe subvalvular and valvular stenosis with typical of antegrade flow still preserved in this patient.
Yes.
So it's like it's more like a DORV with the anterior aorta.
Yes, ma'am. a tricuspid atresia with
Can you, can you show us the relationship of aorta and
It's not normally related to great artery. When you have such a large VST with the tricuspid atresia, in all probability, great arteries are transposed.
Here again, the outflow tract is probably slightly better seen. There's a bit of flow across the.
there is yeah, integrated flow is there. Yeah, the hypoplastic, I think RVOT as well as the branches. That could be because of the, I think.
LPA in this.
Yeah, another branch is not well seen, but yeah.
LPA looks.
So what is the relationship of aorta and pulmonary artery here? Can you show the both together from short axis view?
Yeah.
Okay, so comment about the relationship here.
Aorta is anterior, PA is anterior and right. PA is posterior. RPA looks okay.
So you want to say that pulmonary artery is still aorta is anterior, you said, no?
Aorta is anterior. Anterior and right.
You could say side facing also, yeah. Okay. Yeah, this view is fine.
Glenn circuit.
And you have shown the aorta opening from the which ventricle? Or both great arteries are arising from the same ventricle? What madam is saying. Did you show that? Anyway, so
it was the left.
It is more into the RV now. Aorta is arising from the RV, PA is arising from the LV. This is a TGA actually. Tricuspid atresia with the TGA physiology. So large inlet waste. Glen flow?
Yes, sir.
Glen flow is basic. Smooth basic Glen flow is seen.
Do you feel clinically Glen flow will be normal or it will be obstructed or what?
No, the thing is like for the last few months our symptoms has worsened. There's a possibility that it would have been there would have been some obstruction.
Do you think Glen gets obstructed after 18 years? What is the mechanism of Glen obstruction usually?
Usually it is thrombus.
Usually it is anastomotic, so you get it very soon after surgery. Thrombosis can happen, but such a delayed thrombosis is most unlikely in somebody unless she suffered some insult which has made her hypercoagulable. Otherwise, Glen circuits are, I mean, Glen aneurysms are really broad, wide. They hardly ever obstruct, even with a thrombus. So I don't believe that, she would have developed puffiness of the face if her Glen was obstructed. That is the first symptom that they would get. Not fatigue, not increasing cyanosis.
Why her JVP was so much elevated, you said? Still,
It is 8, isn't it? 8 centimeters.
So it can be because of some resistance to Glen flow, because PA pressure might have been increasing.
Whatever her PA pressure will be, that will be the Glen flow. That will be the SVC. So you expect a higher SVC in patients after Glen.
Okay.
It's not the communication with RA, no, it's communicating with PA. And the PA pressure is going to be 10, 12, even in the best of Glens. So your SVC is going to be that much. It's not going to be 8 or 6.
I think antegrade flow is also there. Most of
antegrade flow is very trickly. I think it's not contributing to the pulmonary blood flow from what it looks like. Priya can correct me, but it looks very trickly.
Yes, ma'am. It looked like just a trickle of antegrade blood flow, and the gradient across it also was more than 100. So I don't think that was too contributory to the
pulmonary blood flow.
Pressure. Yes, ma'am.
Yeah. Okay. So you have the angio, maybe.
Yes, ma'am. Yes, ma'am.
Okay, let's look at the pressure.
This
the angio.
Get ready to go to the future. Bluetooth mode. The device is ready to get.
Blood pressure is 14. And the saturations, obviously, aorta is only 76. So pressures are good. Let's see the anatomy.
Angio, pictorial angio of the right-sided bidirectional vein, AP view. showing good Glenn flows, uh, good aberration of bilateral and long fields, good size branch PS. I am not
Are
able
you
to see obvious pulmonary AV malformations.
how comfortable are you with these PA sides, especially the left?
LPA looks smaller actually. Maybe that is the reason that left-sided lungs were crowded.
No, no, no. Lungs are crowded because of the thoracotomy. I don't think lungs will ever get crowded if the blood flow is reduced. Have you ever
So
seen lungs getting
can you
crowded
go
in
back?
nephrology? No,
Can you
that's
go
a.
back? Yeah.
I think that's a wrong notion that you have. Lungs don't get the ribs don't get crowded because of pulmonary blood flow.
So where is the left upper lobe branches like arborization? You said arborization is very good.
Left upper lobe. Huh? Yes.
On the left side is not there on the right.
Can I show a pointer?
He has had a left BT shunt, no?
Vein is also seen.
That's what he said. Good arborization.
Yeah. So left BT after left BT shunt, this is something you almost always
Expect, no?
you don't see much of pulmonary artery in the upper zone. So that's why you are not seeing it here also. Left side. Right is good arborization, not left. In fact, you can measure left and right pulmonary artery. To me, they look rather small for an 18-year-old.
I think
What would
definitely
you-
will be an issue for a Fontan, I think.
Yeah. Would you like to measure? What kind of index are you going to use? Do you know, Subhash?
Nakata and Magon index.
So,
Yes.
I mean, Magoon you wouldn't be able to do because we don't have aorta, at least not in this NGO. But Nakata you can. And what kind of Nakata, what levels of Nakata index would you take it as
Hyler,
okay for a Fontan?
I,
So here you have Magoon and Nakata. Are you okay with this?
Nakata is more or less.
Actually, Nakata, I don't know, right and left has to be done, I think, separately.
So what is your impression after the catheterization?
That this DTA and angiopictal approaches from the right femoral to aorta.
Question they're asking you is that how comfortable are you sending this patient to Fontan? Are you okay to send her to Fontan?
LPA branch PAs are small, especially LPA, sir. So
Okay.
Yeah, agreed.
So probably Fontan, it's like it's not good. I would not send to Fontan because LPA is quite small.
So you studied her, considering that she could be a case for Fontan, and now you have to make that decision. Has she had any CT angio?
No, ma'am. She's not had a CT.
Okay.
This is the recent admission for a pre-Fontan cath, and she was cath like 2 days back. And
I'm just wondering if her pulmonary arteries are underfilled and maybe better on CT. I'm just
Hmm.
trying to think what next for her.
Yes, ma'am.
What is the saturation like? Resting saturation like?
71.
75 is the resting
Oh.
saturation, sir.
So
Pretty low.
suppose if the surgeons are not really keen for a Fontan, what else can be done? So we get any other simple procedure that can increase the saturation. So actually, in such cases, if the surgeons refuse, I think they are right in refusing a patient at 18 years after Glenn being done at 1 year with such a LPA. So if they refuse for a Fontan, then possibly we can do what is known as carotid to jugular shunt.
I don't know if that doesn't. I don't know how much it helps actually.
I think we have quite a few patients on follow-up who are doing very well. At least they are going on.
Yeah, they're going on, but the saturations have not. At least the ones that I'm following, saturations haven't improved much. But yes, I think some people like to do that. The other thing is, can you give her a shunt on the right side, AP shunt?
Only problem is your left upper lobe.
No, I was just asking Subhash that
I know. No, I'm just asking you.
Can you give a shunt? Sorry, go ahead.
BT shunt.
Yeah, BT shunt. See, basically now our plan is to get her saturation high because Fontan is not a possibility.
We can do.
So what will happen to Glenn flow then? if you give a BT shunt?
Glen flow will become like from aorta to VT. The glen flow, it will flood the lung.
Yeah, glen will not flow because there will be high pressure flow coming from the subclavian. So glen might just all go to the left pulmonary artery and may produce more problems. So giving a BT shunt after a glen is also a problem.
So Subhas, what is the likely prognosis of this patient? Suppose he lives only on Glen. What is likely complication after a few years and what is the prognosis in this patient?
Powering off. Connect again soon.
Sir, I didn't get your question.
Power on.
What is the likely prognosis for this patient?
Your device
Suppose
is ready
the
to
patient family comes to you now, you have explained that this is the diagnosis and now they want to know the prognosis for doing anything. And suppose madam is saying the option of BT shunt in this patient. So what prognosis you will give? Just now continue with the Glen without doing anything versus doing a BT shunt or experimental what Dr. Rama was telling about the shunt, arterial shunt. You have to explain to the family, right? Or a patient
Like
in the adulthood.
at this point, fontan and all we cannot do. Even BT shunt is will create more problems. So most likely we have to put on our medical follow up, and then prognosis with this is like it's like she's unlikely to survive another 10-15 years.
Survival up to the third decade is less likely in this patient. What could happen? What would be the complication of this?
She is having severe hypoxia. I mean, severe. She is having hypoxia, so that may worsen in the future.
So what complications of cyanosis that's being asked?
It can cause polycythemia, that will cause increased viscosity and sir?
Anything else?
Polycythemia can worsen the viscosity and then it can cause stroke.
So tell me what advice are you going to give to the family to keep her as symptom free as possible? You said polycythemia, so you're going to tell them keep her well hydrated. Okay. What else?
First, she has to maintain the oral. She is already having dental caries.
Yes.
There is possibility of infective endocarditis, high possibility of infective endocarditis in this patient. So would ask her to have a good orodental hygiene and a regular follow up to the dentist at least once in 6 months.
Antibiotics before dental work or no?
Yes, sir. To prevent infective endocarditis, before any procedures, invasive procedures, we have to put our antibiotics.
Okay. What else will you tell them?
We can
powering off. Connect again soon.
we have to put our on
Power on. Get ready to go to the future. Bluetooth mode.
although there is a polycythemia, the risk of iron deficiency is also high. We will put our on.
You said she has pyoderma on her legs, healed pyoderma. Does that bother you?
Yeah, it can also cause infective endocarditis.
No, something worse or something more sinister.
It can cause brain abscess. It can
Yes. See, brain abscess is a very important complication in adults. So you have to tell them to take care of all the infections promptly, to keep her well hydrated, not to get her pregnant. I mean, she can get married, but she should not undergo pregnancy. So these are the things you have to tell them, so that her life, whatever is left, is not getting into any complication. That's the idea now. You just cannot say, okay, I can't do fontan, so forget about it, go home. That's not a good way of treating someone.
Okay, Dr. Subhash, I think it was a good presentation overall, but you need to read a lot. Okay. and other people also has to reply during the questions and answer session. It is not just one person, it should be interactive, all students. Okay, and I think we could finish only one case, so another case is less likely, isn't it, madam?
Yeah.
Yes, I think
Yeah,
this
yeah,
case
yeah,
was
yeah.
a difficult
Yeah,
case.
yeah,
So
it's
Yeah, 10,
Subhash,
15 minutes only.
yeah,
Yeah.
Subhash has done well. Unfortunately, his friend couldn't help him, but that's okay. In the exam, also you're going to be all by yourself. So good you got the rehearsal done
pretty
today.
complex case he has chosen actually. All
Yeah,
three,
it's a complex case,
all
but
three
he has done
palliative
well.
procedures. Yeah,
Yeah, but he has done well.
yeah.
I think I would give good marks to him. I would. I don't know, Dr. Jayaranganath, what do you say? I think he's done well.
Yeah, yes, madam. I think he is busy and he is actually our, I mean, final years are all exam going now. I couldn't catch hold of him. I cut hold of him, so he's okay.
This is the
Just,
second year you said, right? One
yeah,
more
he just
year
second,
remaining.
he just second year.
So
No, he's more
lot
than
of
1 year to go. More than 1 year to go. 1.5 years. I think. Yeah.
So
Good.
Hello, 18
lot
months to
of,
go.
yeah, he has a lot of courage also. Second year presenting a long case in
Yeah, yeah, yeah.
technical,
18 months. 18
and
months
that
to
too in
go.
front of the stalwarts like Rama, Madam, and yourself, isn't it? So
But it's going to help him. So
yeah,
I think he will not forget any such case in future. So he's going to do well. So good.
so Sunny,
Yes, sir.
can we close up the session?
Sure, sir.
So on behalf of Dr. Ajay Mahajan and Dheeraj Kumar, I thank you all the participants who has presented the case, and a lot of interaction occurred, and all the faculties, particularly Madam, the Jay Ranganathan sir and Dr. Rama, his good friend, and thank you very much from this our side. Next time, I think again we will come to with via Ajanta. What Ajanta is doing a great work. Yeah, over to you.
Thank you.
Thank you.
Thank you, sir. So I take this opportunity to put formal vote of thanks. So very good evening to all respected doctors. On behalf of entire Ajanta Pharma, I am Sunny Jaiswal, AGM Marketing, taking this opportunity to put formal vote of thanks for making our sixth session of the DMPG 5th Ajanta Cardiomaster Workshop a grand success. Our heartfelt thanks to all esteemed panel members and participating PGs for the presence and active involvement. Would like to specially thank our today's PG speaker, Dr. Subhash Chetri and Dr. Yash Sharma for insightful presentation. We would like to also extend our sincere thanks to our expert speaker, Dr. Anita Saxena Madam, for her enriching and thought-provoking session as usual. Special thanks to our post directors, Dr. Ajay Mahajan sir and Dr. Dheeraj Kumar sir, for the continuous guidance, encouragement, support in shaping this particular academic platform as such. We'd like to also acknowledge our valuable contribution of our expert panelists, Dr. J. Ranganathan sir, Dr. Ramakrishna sir, Dr. Charan Lanjewar sir, and of course today's the guidance given by Dr. Priyadarshini madam as such. Again, a big thanks to all DM and DNB participants for investing your valuable time in learning from the stalwarts of the cardiology. And we highly encourage each one of you to continue to be active participant in our forthcoming balance 2 more workshops. So please do not forget to log in our for 7th workshop, which is on the next Friday on the same time. Again, just to reiterate, the quiz will be live now after 5 minutes and shall open remain next 12 p.m. tomorrow as such. So with this, we conclude our today's 6th DMPG Cardio Master Workshop also. Thank you once again, one and all, and wishing you all a good night and a very happy weekend as such. Thank you, one and all.
Thank you.
Thank you. Thank
Thank
you.
you. Thank you.
Thank you so much, madam. So nice of you. Thanks a lot,
Thank
Charan
you.
sir and Jay
Thank
Ranganathan
you.
sir. So
Thank
nice
you.
of
Thank
you.
you.